Hello all, Dallas Holiday, PGY4 with Midwestern University here with another bedside ultrasound lecture. Today we're going to be talking about the use of ultrasound primarily in the realm of infectious disease. So we're going to cover a lot of topics today. First, we're going to start with the rapid ultrasound in shock and hypotension and discuss how this applies to septic patients. Next, we will cover the use of bedside ultrasound in patients with suspected soft tissue infections. And finally, we'll review the procedure for ultrasound-guided lumbar puncture. So first thing we're going to talk about is the rush exam. So what is the rush exam? The rush exam was created in 2006 with multiple publications since that time. The rush exam is predicated on the success of the FAST exam in trauma and was designed to be a catchy, easy exam for differentiating the cause of shock and hypotension in the medicine patient. The exam covers 5 components and can be accomplished in about 2 minutes by an experienced operator. The 5 areas covered are the heart, inferior vena cava, Morrison's pouch and FAST exam, the aorta, and lung for pneumothorax. You can remember this sequence by the mnemonic HIMAP. Next, we're going to discuss the heart. This is the first organ assessed. Essentially, you can assess the heart in 2 views, the parasternal long view and the apical 4-chamber or subxiphoid view. These views will provide information about the presence of pericardial effusion and tamponade, right ventricular function, and left ventricular function. So this is our parasternal long axis setup. You're going to obtain this view by placing the phased array or cardiac probe at the 3rd or 4th intercostal space to the left of the sternum, perpendicular to the patient's chest. Unlike other bedside ultrasound exams, the probe indicator should be aimed at the patient's left hip. If you're struggling to get your view, make small adjustments in the placement and angle of the probe. Rib shadowing is often bothersome, but can be overcome with some adjustments. So this is what you're going to obtain when you get your parasternal long view. This is primarily composed of a cross-section of the left ventricle, enabling rapid bedside assessment of left ventricular function, dilation, and filling. There's also a small amount of the right ventricle visualized superiorly to the left ventricle, and the pericardium is also seen, which enables us to diagnose pericardial effusion. The mitral valve and aortic valve are also visualized as labeled here. So here we see left ventricle, mitral valve, small amount of the right ventricle, and then our aortic valve here. So this is an example of pericardial effusion with tamponade. This video shows a large pericardial effusion with evidence of tamponade, which can be seen by the collapse of the right ventricle during diastole, which is specific for tamponade. And you can see the fluid as a black stripe around the heart. Small effusions are best identified posterior to the left ventricle. Now this next view shows us a video. This is going to be multiple views, not just the parasternal long, but this is showing us a severely dilated left ventricle. There are more complicated calculations for measuring left ventricular function, which is not the purpose of this exam. The left ventricle size should vary approximately 30% between systole and diastole. Less variation suggests that the left ventricle is not functioning well. Increased variation is consistent with a hyperdynamic heart, which may be due to reduced filling in volume deplete states. This video demonstrates a dilated left ventricle with minimal change between diastole and systole, suggesting severely compromised left heart function. And again, you don't have to do calculated measurements, just sort of eyeball it. If you look at enough hearts, eventually you'll get pretty good at being able to make an estimation just based on looking. So here, this is an example of a hyperdynamic left ventricle. In contrast to the last clip, this video demonstrates a hyperdynamic heart evidenced by almost complete collapse of the left ventricle between systole and diastole. Here's an image of right ventricular strain. The right ventricle should be approximately 60% of the left ventricle size. If the right ventricle is the same size as the left ventricle, this is abnormal and suggests right ventricle dilation, which is consistent with right heart strain. Remember, in a hypotensive patient with right heart strain, you need to heavily consider pulmonary embolism and act accordingly. So next we're going to discuss the subxiphoid view. This is going to be the same phased array probe we were using earlier, and it's going to be placed in the subxiphoid space, pointing towards the left shoulder. This is the same cardiac view as used in the FAST exam, which we should all already be familiar with. This view provides a 4-chamber image and is useful for assessing for pericardial effusion. So again, here, this is the image obtained, and this image demonstrates free fluid, suggestive of pericardial effusion. But you will see all 4 chambers. The right ventricle is easily identified as it touches the liver and should be smaller than the left ventricle, which should be found on the patient's left. This image demonstrates a pericardial effusion easily seen by the black stripe between the right ventricle and liver. So again, up here, you're going to have liver, and then your right ventricle is going to be up against that liver, and it's going to be smaller than your left ventricle located over here and on the patient's left. Next, we're going to discuss the inferior vena cava assessment. Evaluating the IVC allows us to evaluate the tank, i.e. the volume status of the patient. During inspiration, intrathoracic pressure increases, decreasing venous return to the heart. In a hypovolemic patient, this will result in significant IVC collapse. Due to these mechanics, it is not applicable to the intubated patient. It is not infrequent to get patients with underlying congestive heart failure presenting in septic shock. According to early goal-directed therapy, these patients should be bolused with 30 mL per kg. However, we know that these patients may be euvolemic on presentation, and pounding them with multiple liters of saline will result in fluid overload, worsening their clinical situation. For this exam, we will use the phased array or curvilinear probe with the patient in the supine position. Once the subxiphoid view of the heart has been obtained, simply slide the probe slightly to the right. If using the curvilinear probe, rotate the probe so the probe indicator is pointing toward the patient's head. Once the view is obtained, watch the IVC approximately 2 centimeters from the atrium. Now here is your view. Identifying the right atrium is important because it's possible to mistake the aorta for the IVC. During normal spontaneous respiration, the IVC should have less than 30% collapse. More than this suggests volume depletion, or at least suggests that the patient can tolerate IV fluids. So again, up here, you're going to have your right your right atrium that leads into your IVC, and then you'll have some liver and some liver vasculature up here. So here's an excellent video from our friends at 5 Minute Sono demonstrating a nice plump IVC with minimal variation during respiration, suggesting that hypovolemia is not the source of this patient's hypotension. So again, up here you have right atrium, IVC, and we're seeing almost no collapse. So this is not a patient that needs to get a ton of fluid. Another nice clip from 5 Minute Sono demonstrating a collapsible IVC, suggesting that hypovolemia may be the source of this patient's hypotension, and at the very least that they can tolerate more fluids without fear of overload at this time. And again, up here you see the right atrium, which appears to be a little hyperdynamic, at least it's going fast. And then you see almost complete collapse of the IVC during inspiration. Next, we're going to talk about the FAST exam. Just for the sake of time, I'm not going to go into a ton of detail on the FAST exam, as we'll cover it in depth in other lectures. Simply know that it's part of the rush exam to check the abdomen and pelvis for free fluid. The next component of the rush exam is the A and high map for aorta. Using the curvilinear probe, we're going to quickly scan the entire length of the aorta from xiphoid to iliacs, which will split around the umbilicus to assess for evidence of aneurysm and dissection. Remember, abdominal aortic aneurysm is defined as a diameter greater than 3 centimeters. A ruptured aneurysm may be rapidly fatal and result in shock and hypotension, hence why it is included in the rush exam. The risk of rupture is directly related to the size of the aneurysm, with diameters of less than 4 centimeters associated with a less than 2% annual risk, and those greater than 7 centimeters associated with a rupture risk of 20 to 50%. Mortality is directly related to the time of diagnosis, making this a critical must-not-miss finding in unstable patients. And as we know, these patients often cannot go to CT scan due to their instability, making rapid bedside assessment with ultrasound a vital tool. So we're going to be using the curvilinear probe. You're going to find the aorta, essentially in the patient's midline, and you're going to take periodic outer wall to outer wall measurements. If you're struggling with bowel gas and not able to get a good view of the aorta, Often, if you just apply a lot of firm pressure and hold the probe, the intestinal contents will sort of float out of the way. You can also roll the patient in the left lateral decubitus. So start by scanning high in the epigastric region. The aorta is typically easily identified by first finding the vertebrae, which will appear as an echogenic region with shadowing. And the aorta should be just anterior to the vertebrae as a non-compressible pulsating structure. This is called the horseshoe sign. Now, I'm sure you're wondering why you're staring at a sandwich. When I Google image searched horseshoe, this was one of the first images to come up. My first reaction was hunger, but then I wondered, why in the hell is a picture of a sandwich coming up when I search for horseshoe? Turns out the horseshoe is an open-faced sandwich that is considered a signature dish in Springfield, Illinois. Who knew? We will cover the aorta exam more in depth during a future discussion, but these are just the essentials of the exam. As mentioned previously, follow the aorta down until the bifurcation of the iliac vessels. So again, simply what you're going to see is your vertebral body here with shadowing, and the aorta should be immediately anterior to that. Don't get confused with your inferior vena cava. That's going to be a thinner walled, more compressible structure. So make sure you're looking for that pulsating, non-compressible structure and know that you're on the aorta. The last component of the high-map mnemonic is checking for pneumothorax. For this exam, we're going to switch to the linear high-frequency probe and check the lungs bilaterally for pneumothorax. Although pneumothorax is frequently considered in the trauma patient, remember medicine patients may develop spontaneous pneumothorax, particularly in long-term COPD patients who may rupture a bleb or in tall, thin, young males. As discussed in previous lectures, we're going to take that probe and we're going to place it on the patient's chest between the third and fifth intercostal space, with the probe indicator oriented towards the patient's head. The ribs will be visualized as hyperechoic shadows with lung and pleura visible between them. Normal pleura will slide with inspiration and expiration, creating a visible sliding that is described as ants on a log, which we can see here, and again, a nice video from 5 Minute Sono. So here's that ants on a log sliding. Subcutaneous tissues, not a lot of movement here, but this is where we should see all the movement in a normal lung, no pneumothorax. Conversely, pneumothorax is going to prevent normal lung sliding and result in a lack of shimmering. So again, here we've got subcutaneous tissue up here, got some ribs over here. Now this is where we should see that nice shimmering line and evidence of motion, and we don't. It's just a static line sitting there, and that is bad news. In addition, for watching for pleural sliding, one can look for the seashore sign in M mode. Probe placement remains the same, simply switch the ultrasound to M mode. The static tissues will appear as straight lines similar to a barcode, and the sliding pleura will appear irregular, creating the seashore sign. So you can see here's our pleural line, subcutaneous tissues not moving, kind of looking like a barcode, and then you get this wavy pattern that's generated by the lung sliding, and this is normal. This is what we want to see. Now this image shows us the barcode sign, which suggests pneumothorax. Instead of seeing motion in the pleura, the lung and pleura appear as static lines similar to the cutaneous soft tissues. So again, you can see here, up here we have our soft tissue. This is likely our pleural line, and down here, none of that seashore sign. Next, let's discuss ultrasound in soft tissue infections. Bedside ultrasound is a great tool for assessing possible soft tissue infections and can help determine management in cases where there may be occult abscess present. The application is quick and easy since you simply apply the linear high-frequency transducer to the area of concern. This technique can also be used to determine if foreign bodies are present in an area of underlying swelling. It can also differentiate between abscess and inflamed lymph node, which one would obviously not want to drain. So normal appearance of soft tissue on ultrasound is composed of hypoechoic fat and linear hyperechoic regions of connective tissue. So here we have an example of normal soft tissue. This is what we should see. When cellulitis occurs, the tissues swell and edema is represented on ultrasound as the cobblestone effect. This image demonstrates advanced cellulitis with hypoechoic regions of fluid surrounding the hyperechoic subcutaneous fat. So this is all edema that's developed in that subcutaneous fat. And in the appropriate clinical picture, that suggests cellulitis. And again, there it is. Again, another image demonstrating cobblestoning on ultrasound exam consistent with cellulitis. Medicine has been diagnosing and treating soft tissue infections for years without the aid of ultrasound imaging, so why should we use ultrasound for soft tissue infections? Turns out evidence demonstrates that ultrasound guidance in cases of cellulitis led to a change in management of approximately half of emergency department patients in this study. Patients were assessed by a physician prior to ultrasound imaging, and a treatment plan was generated. Then bedside ultrasound was performed and resulted in a change of plan in 56% of patients where pre-imaging evaluation did not indicate drainage, and a whopping 73% of patients who were destined for drainage. This is important when we consider the implications of subjecting the patients to a painful, scarring incision and drainage unnecessarily. This is great evidence to incorporate routine bedside ultrasound of soft tissue in your practice. In addition to identifying cellulitis, ultrasound is useful for finding abscesses, particularly occult abscesses in the setting of cellulitis, as we just discussed. As shown here, an abscess will appear as a hypoechoic black region on ultrasound. Ultrasound can also determine the optimal place for drainage to occur. Finally, let's discuss ultrasound-guided lumbar puncture. The use of ultrasound-guided LP technique is becoming more and more salient as obesity rates rise in the U.S., continuing to make landmark-guided lumbar puncture difficult. This exam may be completed with the curvilinear or linear probe, depending on the size of the patient. Larger patients may require the curvilinear probe to visualize the structures, as they've got a lot of subcutaneous tissue over top. Keep in mind, this is not real-time guidance. The ultrasound is simply used to determine the placement site when landmarks are difficult to palpate. The patient may be placed in the seated or lateral recumbent position as in standard LP setup. First, take the probe and place it perpendicular to the longitudinal line of the spine at approximately midline. The purpose of this view is to identify the hyperechoic spinous process to mark the true midline. And again, the patient pictured here isn't really going to be the patient that we're going to be doing this on, because obviously that patient is probably someone you can find the landmarks by palpation, but for the sake of imaging. Identify the hyperechoic convex spinous process with shadowing behind the hyperechoic region. This hyperechoic portion may not be completely evident, and you may just have to rely on shadowing. So again, got a bright spot with a bunch of shadowing behind it, which suggests spinous process, but you might only see this shadowing. So just keep that in mind. Then you're going to use a permanent marker to mark the anatomic midline as demonstrated in the image. Next, you're going to turn the probe to align with the longitudinal plane of the spine and scan over the anatomic midline established during the first step, approximately third and fourth or fourth and fifth interspinal space in the lumbar spine. The goal again is to identify the spinous processes, but now we want to find the interspinous space. Once again, we will find the hyperechoic spinous processes, but this time we will mark the space in between the spinous process for needle insertion, essentially creating a crosshair target for the procedure, as shown here. Once the target is completed, prep and drape the patient, insert the needle towards the umbilicus. So as you can see here, we're marking our anatomic midline, and then here we're marking our interspinous space, and then we basically create a crosshair, and this is where we're going to be inserting the needle. All right, you guys, thank you as always for watching. Feel free to reach out with any questions and continue to scan on. And if you would like to check out any of these resources for yourself for a little more reading, here you go.